Thank you so much. And now we will ask Peter Clemmensen about combined Impella and ECMO in cardiogenic shock again. We are continuous, so important topic, how we can save patient lives.
Thank you so much for the invitation, Jim. It's great to be back here again. And I'm a split person, as you know, and I'm even more split this year because the data I'm going to present are coming mostly from out of Scandinavia, although I still have affiliation there. These are my disclosures. And I think the background for this talk is really that we abandoned the aortic balloon pump after 40 years where it served us so well, we thought, and of course this was all provoked by the study by Holger Thiele. And we also know that inotropes in cardiogenic shock are inadequate and also have adverse events that I'm not going to go into. And with this in mind, actually what we've seen across Europe and also the US is a move towards immediate escalation in these patients who have cardiogenic shock, where we bypass the old instruments and go immediately to ECMO or Impella. But also, as you know, ECMO has its side effects. So just a couple of slides to go over the principles of the extracorporeal oxygenation in ECMO in patients with cardiogenic shock. As you know, it is usually done during ongoing CPR or right after if you have a return to spontaneous circulation with this venous and arterial bypass, where you take the suck the blood out of the vein in the right atrium, and then you reinstate it in the abdomen, where you then have a counterpulsive flow going in the contrary direction to the blood flow anatomically. Now, if you look at some of the data that have been widely cited, one study is by Chen et al. That is mandatory if you write on this topic, where you look at ECMO in patients who had in-hospital cardiac arrest, and you can see that the patient who also had a ECMO had this very great survival benefit that you can see on the blue line compared to the patient who did not. Now, important, although they have a lot of patients in this study, this was all witnessed arrest in hospital, and the duration of the CPR was more than 10 minutes if you had to be recruited for this study. However, I think importantly also, if you look at this paper more closely, because on the right side you actually see the uncorrected data, but when they did a propensity match score that you can see on the left side, you can actually see that in the patients, the 46 that had the extracorporeal circulation, compared to the right column, the 46 that had a conventional treatment, then there was a lot of these differences actually disappeared. If you look at return to ROSC on the top, it was actually one of the ones that actually met the primary endpoint, and also there was a trend towards improved survival if you look at the mortality on day 5. However, if you look at the status at 1 year, there was no significant difference between the two groups. I think this is important, that although we are enthusiastic about the ECMO, really data are quite scarce. This is another study that looked at a lot of patients that received an ECMO for various reasons, because of failure to wean after bypass surgery, in MI with cardiogenic shock, patients that had some kind of injury or infections, including myocarditis and septic shock. And you can see here that the long-term survival, when you compare these groups, is actually quite similar. One thing I think that is an important take-home message, if you look at these data, is no matter what is the entry criteria, what is the indication to use an ECMO, if you look at the duration, regardless of the indication, if you look at the mortality, if you go out past 3 days, so 3 to 5 days, you really have a really dismal prognosis in this particular but very large study of more than 4,000 adult patients. Despite these caveats, this is quite old data, but this is showing a steep increase, at least until the year 2011, of ECMO use in the United States, and I would expect that it would be continued in use and increasing. However, the ECMO does have some complication, as you might be aware of. Leg ischemia, the most imminent, but other vascular complications, also bleeding. You have a number of patients who actually experience the true circulation syndrome, where you have good perfusion of the lower body, the kidney, the intestines, and also the lower extremities. However, the two main organs you want to protect are actually hyperperfused, namely the heart and oftentimes the brain. Another problem, of course, is the left ventricular distension, and also patients that go into pulmonary edema because they need volume to have the ECMO running. And you have problems with hyperfibrinolysis and embolism, and also in some cases you can see an abdominal compartment syndrome that needs to be taken care of on an emergent basis by our colleagues in the abdominal surgery department. Now, if you look at sort of this is European guidelines on the top, you can see that actually it's a 2B, and the class of indication or the level of evidence is actually C, because we have no randomized data. But short-term mechanical circulatory support should be considered in refractory cardiogenic shock, depending on age, comorbidities, and neurological function. But it is there in the guidelines for us to use at a height-quite recommendation level. Now, some of the problems that you see with ECMO is, I've tried to show on this pressure volume loop basics that you see here in the blue with the left ventricular pressure and the volume curve. And then you have the red line with the systolic contraction, and the dotted red line, the afterload. So what you see in cardiogenic shock, of course, is a shift of this curve that goes downwards and to the right, and you have a smaller loop in cardiogenic shock, as expected. But what is actually happening when you implant a VA ECMO in these patients is that you increase the afterload quite tremendously due to the retrograde femoral flow in cardiogenic shock patients. So this is what you see. Now, in theory, what you want to do with any mechanical intervention or with drugs is actually to shift this curve backwards and try to obtain some kind of unloading in these patients. And this, of course, for this purpose, the Impella is actually an excellent choice if you want to vent the left ventricle if you start to having dilatations, mitral regurg, or pulmonary edema. Another of the issues, of course, is the pathophysiology of the ECMO, that is the watershed. This is where you have the antegrade flow from the aorta or from the left ventricle leaving, and you have the retrograde flow coming from the VA ECMO. And depending on the outflow of the left ventricle or the force of the left ventricle, this watershed can be right above the aortic valve, or it can be further downstream. And you see this slide here showing the perfusion of the carotid artery. In this particular case, you actually have where the antegrade flow with the less oxygenated blood from the left ventricle to the right carotid, and you have the VA ECMO blood oxygenated going to the left carotid artery. Just showing some of the major issues that you have when you treat these patients. Of course, one of the feared complications that you see down here, movie not shown, but you can see this is actually complete thrombus formation in a patient with almost left ventricular stillstand during ECMO treatment. Of course, one of the most feared complications in these patients, and a reason why you should be very particular about the anticoagulation. Now, the ECMO, of course, support the abdominal organs, the kidneys and so forth, as already mentioned. But the cardiac flow reduces, and you have LV thrombus and pulmonary congestion developing often after a couple of days of use. And the question of how to unload was actually addressed recently in a paper that came out joint from Italy and Germany. That is the concomitant implantation of Impella on top of a VA extracorporeal membrane oxygenation, or ECMO. So this is a quite small study and a pilot with 34 patients compared to 103 patients who were treated conservatively. And if you look at the data, now fast because my time is running out, you can see here that these were younger, 54, 55 age group. They were mostly males, a difference in the presentation, whether it be STEMI or not. And you can see they were pretty sick with pH values of 7.36 and lactates in the area of 9 to 10. However, a match control study was done in these patients looking at the ones ECMO plus Impella 21 and ECMO alone in 42. And you can see the match was pretty well taken care of if you look at the baseline variables. And most importantly, in this match control, you actually saw a decrease in the mortality, as you see on the top here, from 74 to 48%. And there were also other of the known complications to ECMO that were actually favoring the combined treatment if you look at these patients. I will not go over this in detail, but I'll happy to hand it over to you later on. Just looking at the single center experience of this very small study, you actually saw almost a 50% decrease in the mortality in the University Center in Hamburg when you looked at these particular data. Now, clearly, despite these positive tunes, future research is clearly needed, and we have to mandate more randomized clinical trial in these very sick patients. And also, one of the questions, of course, is what is the timing of Impella implantation in these ECMO patients? Should you do it immediately, or should you wait until the patient starts to have pulmonary congestion? And what about right ventricular failure or biventricular failure, as was shown in the first case from Odense University Hospital this morning, a very beautiful case where you see the combined treatment with both cases. So in conclusion, ECMO therapy seems to save life in refractory cardiogenic shock. We all have case stories. Definite data is not available to support this from randomized clinical trials. Venting of the left ventricle when it is dysfunctional in VA ECMO patients via Impella use seems promising for reducing mortality, and an ongoing registry and hopefully pivotal trials should prove this concept in the future. Thank you for your attention.
Yeah. Thank you, Peter. Comments, questions?
Yeah, actually, it's. I guess it is really it's a hard topic because this is very difficult, and this is I guess it's from I don't know from how many years from shock trial that it's very difficult actually to randomize patients, a shock patient, and that I guess we need some we should use only registries. And actually, what do you think? How we can really to get this point, and how we can actually to change this guidelines class from to B and C level, you know, it's only expert level, and how we can change this.
Well, I think you know, I like your thoughts, but I don't agree with the concept that we cannot randomize those patients who are most in need. I mean, compared to the trivia of comparing different anticoagulations in atrial fibrillation, just to take one example, I think these are the patients that have a mortality of 50 to 80%, and we need to randomize them if we have to improve. And I think we have shown, not we, but others have shown that it is possible. And just ending on this with the last note of Karisanamäki, the culprit shock trial is actually finishing probably in the next 6 weeks. That has occurred in Germany and many other European countries, that has actually shown that it's possible to randomize patients in severe cardiogenic shock towards you know, full revascularization or target only. And we're going to see probably at the ESC or the American Heart, the outcome. So it is possible, but you need very simple tools. You need to have very simple tools in the cath lab to randomize these patients so you don't waste time, because this is something you don't have.
Yeah, no, I didn't say that I don't like randomized. I said that people don't like
know.
randomized, and this is a big deal, because I know it's a very big, huge project, and planning somewhere in Europe and Horizon project, and I guess we also participate there. But
But I think it
this-
falls back
but,
on us who
yeah.
actually treat these patients to make sure that we also do the right trials for the
Yeah.
future. Yeah.
Great.
Yeah, okay, thank you, Peter.
Yeah, but
Let me just, let me say
just-
one thing about randomizing.
Yeah.
When you have an endpoint that is as frequent as death as in cardiogenic shock, it's relatively easy to randomize because you don't need very many patients to show a difference.
Exactly. The culprit shock will at the end randomize 800 patients, if I'm not mistaken, when they close randomization in 6 weeks.
You can probably do it with 100 or 200 or fewer.
Right, but you have some other endpoints in culprit shock, like renal failure and renal replacement therapy. So yeah, but good point.
Okay, thank